My name is Bill Sterba. I'm an orthopedic surgeon at OAD Orthopaedics. I'm a sports medicine specialist. Today we're going to be talking about the anterior cruciate ligament and injuries to that ligament. The anterior cruciate ligament is probably the most studied ligament in the body, and it's certainly one that is most well known, in large part because of the number of athletes which sustain this type of injury. We're going to talk today a little bit about the anatomy. We're going to talk about the injury and how orthopedic surgeons can repair this injury and return athletes back to their previous level of sport and activity. The bones of the knee, this represents the tibia or the lower bone or the leg bone. This part here represents the thigh bone or the end of the thigh bone or femur. And this part here represents the patella or kneecap. This is the patellar tendon, and this is the quadricep tendon, which is the thigh muscle itself. And the patellar tendon connects that to the tibia and allows you to extend your knee. You have other ligaments around the knee, such as the medial collateral ligament on the inside part of the knee. This is a right knee model. And then on the outside, you have a lateral collateral ligament. Within the knee itself, there are two meniscus. There is a medial meniscus, which is here, and the lateral meniscus here. These are cushions which help to distribute the weight of your body over a larger surface area, and they provide some stability as well. They are also commonly injured. Now, inside are the cruciate ligaments, or the ACL, or anterior cruciate ligament, and in the back you have the posterior cruciate ligament. This posterior cruciate ligament has been sectioned, and injuries to that are less common. The anterior cruciate ligament is this here, this ligament right here. And though it's a fairly small ligament, it serves a very important role in that it prevents the tibia, the lower bone, from sliding forward on the knee. And that is commonly the mechanism in which you see athletes, oftentimes on the slow motion replay, you can actually see the knee shift, and that usually signifies an injury. Now, the injury to the anterior cruciate ligament commonly occurs without any type of contact. That question is commonly asked, that, does there have to be a tackle, or does someone have to hit the knee? Most injuries actually occur with a plant and pivot type of maneuver when you're changing directions at a high rate of speed or high rate of force, and the ligament gives out. The force directed across that exceeds the ability of that ligament to hold, and most of the time patients will report a history of a pop. Generally, you're unable to walk after that or have difficulty doing so. The knee generally swells fairly quickly within the first 30 minutes, and typically you're unable to return to that level of sport. So the injury to the ACL typically occurs through the mid portion of the ligament, and when we see a patient that comes in reporting a pop with knee swelling, one of the things that we'll do is test multiple parts of the knee. We'll test other ligaments which can be injured. We'll also look for injuries to the meniscus which can occur, and we'll test the ligament as well. And oftentimes you can see trainers and sideline physicians doing this in their test, which is called the Lockman test, which you're trying to bring the knee forward and actually testing to see the integrity of the anterior cruciate ligament. When an injury such as that is determined, typically initial treatment is going to be crutches, it's going to be limiting activities, it's going to be icing, using anti-inflammatories in order to reduce the swelling around the knee. But you need to get in and be evaluated by an orthopedic surgeon, and that surgeon will most likely order an MRI or magnetic resonance imaging to take a picture of the whole knee itself, and it will show very clear images of the anterior cruciate ligament. It will show clear images of what the condition of the meniscus is as well. Once the diagnosis is confirmed, usually there's a follow-up meeting with the orthopedic surgeon to discuss treatment options. Typically, as this occurs in athletes and younger individuals who want to maintain their level of activity, whether that's competitive sports at the high school, collegiate, or professional level, or even a recreational athlete who participates in competitive softball leagues, tennis, racquetball, really any sport which requires any type of change in direction. So the orthopedic surgeon is going to discuss with you what your treatment can be and whether you're a candidate for surgery or not. So you and your orthopedic surgeon will make that decision of whether reconstruction of the anterior cruciate ligament is what is required and what direction that you want to proceed. Not everyone that has an anterior cruciate ligament injury will require surgery or request surgery, and some individuals are treated without surgery and do reasonably well. Generally, they don't return to sports such as running, cutting sports, but oftentimes are able to play golf, certainly able to walk, and some individuals are able to cope with the injury. Most commonly, though, when an anterior cruciate ligament injury occurs, surgery is recommended. That decision has to be made between you and your orthopedic surgeon who is evaluating you, and that discussion can take place in his office. Typically, when an anterior cruciate ligament occurs, there is no way of sewing the ligament back together. I get that question a lot. If we can take suture and actually physically sew the ligament back together, or whether it heals by itself. Both of these methods have been tried in the past and they have failed and they have not worked. So what orthopedic surgeons have to do is we actually have to rebuild the ligament or reconstruct the ligament. And that's called an anterior cruciate ligament reconstruction. In order to do that, we take what's called a graft, which is a tissue from another part of the body, or sometimes from a cadaveric specimen or someone who has donated their tissue, and we use that to rebuild the ligament. In order to do that, we generally drill a tunnel in the tibia and we have a tunnel in the femur, and we then pass the graft through those tunnels, affix it within the tunnel here on the femur, tighten the ligament, and fix it on the tibia here. Typically, the discussion is going to revolve around three main graft choices. There are other multiple graft choices, but the most common ones that are used are the patellar tendon, which is taken from the central portion of the patellar tendon with a bone plug from the tibia and a small bone plug from the patella. The second graft choice, also taken from the patient itself, is from the hamstring tendons where they insert on the tibia. There are hamstring tendons that insert here, and it is a incision which is a little bit smaller than the patellar tendon incision, which is directly in front of the knee, but it is more off to the side, slightly more cosmetic, and the tendons are taken, folded over and doubled. They are sewn together, and then they are passed through and affixed in a slightly different fashion. The third graft choice is the cadaveric specimen, or the donor graft. And there are multiple choices with that. There's a donor patellar tendon, which is similar to your own patellar tendon or autograft. There's a donor hamstring tendon. There is donor Achilles tendon, which is commonly used. And those are probably the most common. There are other tendons that can be used as well, which are less common. There are pros and cons to all three of the grafts that are used to reconstruct the ligament. The patellar tendon itself, because we're taking it from the front of the knee, is a little less cosmetic. There's an incision in the front of the knee. It also involves taking a piece of bone from the patella as well as tibia, and sometimes there can be some knee pain that's associated with that. The hamstring tendon is taken from the side and is a little more cosmetic, and it is a very strong graft, but it does take longer to recover from that. And the patellar tendon is generally a faster recovery overall because you have bone plugs on either side. The hamstring tendon usually is a couple of months longer in its recovery phase, allowing that tendon to become the new anterior cruciate ligament. The cadaver is probably the least invasive to the individual. That involves a very small incision, just large enough to make the bone tunnel through the tibia, and involves fixing it on both sides without taking any of the host or patient tissue. So there's the least damage to your own knee. However, it does have the longest period of time before we're able to return to sport, even a couple of months longer than what we use for the hamstring graft. Further, in young individuals, there have been several studies which have suggested that there's a higher incidence of recurrence of graft rupture in cadaveric donor tissue used in individuals under the age of 25. The appropriate graft choice should really be a discussion that you and your surgeon have to find that graft that best fits you. Recovery from an ACL injury it does take a long process, and in part the length of that recovery depends on some of the injuries that occur along with it, such as injuries to the meniscus, which may require a repair, it may require a removal, or if there's other injuries such as collateral ligament injuries, which would involve an injury to the medial collateral ligament or the lateral collateral ligament. Generally, our first, when the patient has an anterior cruciate ligament that is an outpatient surgery, you're able to come in the morning, have that surgery, which is arthroscopic, except for the small open portion, which is involved to harvest the graft tissue, and then have the operation itself, reconstruct the ligament, and then generally we're able to send you home for recovery. Oftentimes for this surgery, we use what's called a femoral nerve block, which allows for good pain control after the surgery and allows you to go home and be comfortable in the first 12 to 18 hours after surgery. In the recovery period, generally there's an early follow-up within 1 or 2 days in which a dressing change is performed, the incisions are inspected, and generally at that time we recommend a physical therapy evaluation, and physical therapy really begins. Generally, physical therapy involves, in the first 3 to 4 weeks, frequent visits of 3 to 4 times a week. Oftentimes, you'll require treatment in order to help regain your range of motion. A CPM is often used at home in order to help you regain your motion. A CPM machine is called a continuous passive motion machine, and that allows the machine to slowly bend your knee back and forth in order to regain your motion more rapidly. Further, you may be sent home with a polar care device, which is a small device that has tubes that go to a machine that provides cooling water to your knee in order to continue to control the swelling and pain after the surgery. As your range of motion improves and as your muscles control improves, we gradually are able to let you begin walking on the knee without a brace. Some surgeons do not use a brace and allow early weight bearing with the patient as well. That should be discussed with your surgeon at the time of your visit. Eventually, after you've gone through several months of physical therapy, the therapist will likely discharge you, but will give you a specific home exercise program. There are protocols that we follow as you're going through your rehabilitation, many of which are tailored. They're tailored based upon the presence or absence of other injuries, such as meniscus repairs or other ligament injuries which occur at the same time. Generally, return to sport can be anywhere between 6 and 12 months after surgery, depending on the severity of the injury as well as the graft type that is used. In summary, the anterior cruciate ligament is one of the most commonly injured ligaments. There are several 100,000 injuries which occur every year and several 100,000 reconstructions of the ligament. Orthopedic surgeons have a goal to return you to your prior level of function and ACL reconstruction is an excellent way of doing that.